from the adrenal medulla. So they get the high blood pressure. Later they may go into the essential hypertension even. Stress and the diet also may be contributing. So because it happens that, so when we also even we prefer to get a lot of fiber, places are not available. So that is a problem.
Thank you, Professor Msiri. Shall we get on to the next paper? It's on association of cardiovascular risk factors, LDL, ApoB, ApoA, and lipopathy and coronary artery disease by Doctors Perera, Wickramasinghe, Peiris, Chandrasena, and Senaratne, presented by Dr. Vascular Perera, Department of Biochemistry, Faculty of Medical Sciences, University of Sri Chavadalapura.
Good morning, co-chairs, ladies and gentlemen. My presentation is on association of cardiovascular risk markers, LDL, ApoB, ApoA1, and lipoprotein A and coronary artery disease. Ischemic heart disease is the leading cause of death in the world and accounts for nearly 12.5% of deaths worldwide. It's not different in Sri Lanka as well. In Sri Lanka, it accounts for the highest mortality rate among the ICD classified diseases as well. When we do the risk stratification for ischemic heart disease, we usually categorize them into two main categories, the traditional risk factors and the emerging or the novel coronary risk factors. So in here, we were mainly concerned about novel coronary risk factors along with the LDL. We'll talk a little bit about apolipoprotein B. It exists in two forms, one as ApoB48 and also as ApoB100. Now dietary triglycerols and free cholesterol that we get from our food is absorbed from the gut and it complexes with the B48 to form the first chylomicron. Then comes the ApoB100, which is present in low density lipoprotein or cholesterol, LDL-C, our VLDL, our IDL, and also the lipoprotein small a as it is referred to. Now what is the function of ApoB100? ApoB100 is essential for the binding of LDL particles to the LDL receptor, which itself then is allowed the cell to internalize the LDL. Coming to apolipoprotein A, there are two forms, ApoA1 as well as ApoA2. Now ApoA1 is the major apolipoprotein found in our good cholesterol, the HDL-C. It's involved in removal of excess cholesterol from tissues and incorporating into HDL. And also it acts as an essential cofactor for LCAT or lecithin cholesterol acyl transferase. Coming to ApoA2, it plays a key role in HDL metabolism. And increased ApoA2 decreases the protection. I'm highlighting that it decreases the protection against oxidative modification of LDL and reverse cholesterol transport by HDL. So when we talk about apolipoproteins and atherogenicity, something that comes up in the literature is the response to retention hypothesis. Now, ApoB containing lipoproteins ability to promote, according to this hypothesis, to promote atherogenicity depends on four main factors. One is the plasma concentration of atherogenic lipoproteins, how much is there. Then the difference between the arterial wall influx and the efflux of atherogenic lipoproteins. In other words, how much of it is retained, the retention of atherogenic lipoproteins in the artery wall. Then third point is the modification of the protein and lipid moieties of the retained lipoproteins, and then finally the inflammatory response to the modified retained lipoproteins. Thus, the presence of ApoB in atherogenic particles leads to the entrapment of these lipoproteins in the arterial wall, leading to atherosclerosis. What about lipoprotein small a? It's also a class of lipoprotein structurally related to LDL. Why? Because both possess one molecule of ApoB100 per particle and have somewhat similar lipid compositions. However, there is a difference. Unlike LDL, LPA contains a carbohydrate-rich protein, the aposimple A, or aposmall A it is referred to, that is covalently bound to the ApoB100 through a disulfide bridge. Its function is thought to be related to triglyceride metabolism and is supposed to be associated with thrombotic and atherogenic pathways. So, the objective of our study was to determine the association between serum ApoB, ApoA1, lipoprotein small a levels in patients with coronary artery disease confirmed on coronary angiography findings. So, selection of study subject. A case control study was carried out with 75 patients, 58 males and 17 females, 40 to 60 years of age, confirmed as having CAD on coronary angiography findings, and 120 healthy volunteers as controls within the same age group. The biochemical analyses were done. Serum samples were analyzed for ApoA1, LDL, ApoB, ApoA1 and lipoprotein small a on a CornEXT fully automated clinical chemistry analyzer. Data analysis was done using SPSS for Windows Statistical Package version 15 and Minitab. Differences were tested by using independent sample t-test. All the volunteers were recruited after giving them the necessary information and after obtaining informed written consent, and the study protocol was approved by the Ethics Review Committee of the Faculty of Medical Sciences, University of Sri Jagadhanpur. So when looking at the findings, when we did the independent sample t-test comparing patients and controls, this is what we got. So we found significant, statistically significant levels between LDL, apolipoprotein B and lipoprotein small a. As more than one risk factor was identified, we did the multivariate logistic regression analysis. And here what we found is that positive family history, ApoB and LP small a were again giving us significant values. So patients with CAD had significantly high serum LDL-C, ApoB and LPA levels compared to control subject. However, serum ApoA level did not show a significant difference between the two groups of our study. Subjects with a positive family history of CAD, increased serum LPA and increased ApoB appear to be at more risk of developing coronary artery disease according to the finding. So family history of heart disease was the most significant risk factor for CAD in this population. And most previous studies done on the topic in the country were dependent on measurement of our traditional lipid profile than lipoproteins. However, our study suggests that increased levels of lipoprotein may raise burden of CAD risk in the Sri Lankan population as well. Thus, measurement of different forms of lipoprotein may improve cardiovascular risk prediction in our subjects. So, findings of this study indicate that serum LPA and ApoB to be useful diagnostic markers of CAD, but always remembering that this is a feasibility study that we have done with a smaller sample size. These are the references. The authors would like to acknowledge the university grant given by the University of Sri Jagadhanpur and all those listed, including the Department of Family Medicine, the National Hospital, and especially the ones who volunteered to join our study. Thank you.
Dr. Perera, I have two questions for you. One thing is, you said that you selected the age match control group for this study. Right. Now, how did you select these? Are they angiography negative people, or at least have you done a stress test on these people? Because you can have asymptomatic heart disease.
Yes. Yeah. The CAD patients are okay, they were angiographically proven ones. Others were also from the cardiac unit. From one of the co-authors is from the NHS, that is after stress test.
Yeah. So they have excluded ischemic heart disease on...
they could go to stage 3 or 4, sir.
The stress test. Fine, right. Second thing is, now what is the practical implication of this? Now we all know from the studies that statins definitely decrease the mortality of the cardiac patients, and if the LDLs are high, or if there is abnormality in the ratio, or if there are predisposing factors like poor family history of premature heart disease or strokes, or if they are having diabetes, hypertension, we invariably put them on statins, and we try to maintain the LDL levels below 100 or even below, depending on the cases.
Yes.
So are we actually, if you are going to identify these sub fractions of these risk factors, is it cost effective? Because the overall statin treatment has definitely decreased the cardiac mortality in the studies.
Yeah, this may be important in certain two situations, whereas especially in younger people. That is because this is just a start of a new topic but in certain other countries, in the Americas, for example, apolipoprotein B and A are in the lipid profile level. So not in our country, but LPA can be done. So to answer your question, yes, we have to start statins and go on. But I think in certain populations, we may have to think of these things as well, because especially LPA is there in people with familial hypercholesterolemia sometimes. What we call collectively as familial hypercholesterolemia, you may find that the LPA levels are higher. So although it may not be applicable to the whole population as such, still we don't know, because as I told you, the sample size is very much less, but we may have to think of it. And yes, statins at the moment we are not going to dispute that at all, but we'll have to wait for the major study results to see how it is.
Yeah, and even if, in fact, if they are below 40 years of age or even younger patients, if they give a very bad family history of ischemic heart disease, we put them on prophylactic
statins. Yes, we can. Yes, because risk stratification, as you know, sir, is based on the LDL as well. We do the full risk stratification at that level. Even the age, family history comes into play. Yes.
Thank you.
So I have one comment, and actually the two questions I wanted to ask, Professor Sadar Singh already asked. The comment is, in the introduction you mentioned that the mortality of coronary heart disease is 12.5%. Actually, all over the world, even in the WHO report, it said it's between 30 to 40%. Whether it's a developed country or an underdeveloped country, all over the world, the mortality of coronary artery disease with myocardial infarctions and ischemic cardiomyopathy is 30 to 40%. It's much higher than what you have mentioned. So when you also include strokes, because it's the same pathophysiology, that even can increase up to 50%, right? Yeah. The cancers is about 20 to 25%. So it has to be...
CAD is the number one. Yes, I agree.
Okay. The second thing is, now, when there is a control group, you have to select the controls in the same way you have selected the... So in the NHSL, there are many negative coronary angiograms, I am sure. So you could have selected some age match, normal angiogram patients, then it would have been much more meaningful.
We tried that, sir, but unfortunately then we ran into problems of getting the numbers because the study was going on for a little longer period. Yes, ideally that should have been the case, yes.
Third is like the lipoprotein little a, we knew for a long time it's associated with coronary disease, but the problem is what are the therapeutic indications, because it's not, you can, like the family history, you can find a risk factor, but there should be a way of treating and reducing the risk. So if they are already on statins, there's no other medication that we can specifically reduce the lipoprotein little a. That is why we don't routinely measure that, isn't it?
But then it can be used as a screening tool.
Yeah.
That is where the importance comes in, not just to sort of see and then trust treatment. So at the screening level, if we can do the LPAs and detect them early, then we can start on the statins earlier.
Okay. Yeah. All right, thank you very much. But it was very interesting and nice study. Thank you.
Any other questions from anybody? Yes, Dr. Vasanta.
Yeah, this is an interesting study, but can I know whether you looked at other comorbid factors like diabetes in these two groups? Did you match that?
All the traditional risk factors were looked into. Only thing is I didn't put everything into that because I wanted to highlight the main points only. Yes, all the risk factors were looked into.
Is lipoprotein little a lighting up as an isolated finding or always with the raised cholesterol and other things?
Isolated findings. So that is why sometimes you may get a normal LDL level and then still you may have a high LP. That's where I think the screening is important.